Hello everyone, it's 9 o'clock Beijing time on the evening of April 10. Welcome to the global live streaming, Preparing for a Pandemic, Lessons Learned from COVID-19. This webinar is hosted by China Association of Medical Equipment and supported by Mandarin as well as AMI, ACCE, IFMB, and AIIC. This is Zheng Kun, the Vice Chairman of CCCE, Chinese College of Clinical Engineers, the Director of Logistics Service Department of the Children's Hospital, Zhejiang University School of Medicine. It's my honor to be the moderator of this webinar. Nice to meet you all here online. Recently, China has made interim achievements in COVID-19 containment with the whole nation's arduous efforts, and the overall situation of pandemic control keeps a good momentum. In the present, coronavirus spreads rapidly across the world. We hope the experience and practice China has acquired from pandemic prevention and containment will be helpful for other countries to curb the epidemic. We are honored to have 5 clinical engineering experts from China, USA, and Italy with us today. Each of them has been working on the front line of the COVID-19 pandemic. They are Dr. Zhang Qiang, Vice Chairman of China Association of Medical Equipment, Vice President of Wuhan Union Hospital affiliated to Tongji Medical College of Huazhong University of Science and Technology, Ms. Chen Hongwen, Vice Chairperson of Clinical Engineering Committee of China Association of Medical Equipment and Director of Clinical Engineering Department of Nanfang Hospital, affiliated with Southern Medical University, Dr. Samantha Jacques, Vice President of McLaren Clinical Engineering Service, McLaren Health and representative of AMI Healthcare Technology Leadership Committee, Mr. Mike Busdicker, the System Director of Clinical Engineering for Intermountain Healthcare in Utah, USA, and representative of ACCE, Dr. Ernesto Iadanza, the Professor in Clinical Engineering and Research Fellow at the Department of Information Engineering, University of Florence, and the Chairman of IFMB Health Technology Assessment Division and former Chair of IFMB Clinical Engineering Division. Thanks so much for taking time out of your busy schedule and joining our webinar. They are going to share their experience and lessons acquired in the fighting against COVID-19. In addition, warmly welcome Ms. Hou Yan, the Vice Chairperson of China Association of Medical Equipment and the former Director General of Planning and Information Department of China National Health Commission, and Ms. Li Zhanwen, the Senior Vice President of Mandarin Group. First of all, let's welcome the Vice Chairperson of China Association of Medical Equipment, Ms. Hou Yan, to deliver her address. Program Director, please shift to the camera for Ms. Hou.
Welcome to this session for sharing China's experience in combating COVID-19. Today, we're going to focus on the application of medical equipment in pandemic prevention and containment. First of all, on behalf of the host, China Association of Medical Equipment, please allow me to express our deepest respect to all the medical staff and medical engineering professionals fighting on the front line against COVID-19, as well as heartfelt thanks to Mindray, the organizer of this session. The COVID-19 pandemic broke out all of a sudden after months of arduous efforts made to respond to the outbreak. China has seen positive changes in prevention and containment of the pandemic. Transmission in the epicenter Wuhan and even across the entire country has been basically curbed. The overall situation of pandemic control keeps a good momentum. During tackling the COVID-19 pandemic, medical equipment, including ventilators, monitors, infusion pumps, ECMOs, mobile DRs, portable ultrasound equipment, and so on, have played a key role in patient diagnosis, monitoring, and rescue. thanks to the collaboration of medical engineering professionals and medical staff. Critical days are ahead for the global community to fight against COVID-19. At this crucial moment, China Association of Medical Equipment initiates this webinar to offer a platform for the clinical experts and medical engineering professionals fighting against COVID-19 at the front line in China to share their experiences and practices with colleagues from fellow nations. We believe such kind of communications are quite helpful for pandemic containment and treatment optimization. Honorable experts and dear friends, virus is the common foe of mankind. Today, what is needed in the global community, so interconnected in a shared destiny, is solidarity against the virus and joint efforts to surmount whatever difficulties that lie ahead. China Association of Medical Equipment is willing to forge partnerships with more international colleagues and to make due contributions to the global combat against COVID-19. Thank you.
Thank you so much, Ms. Ho, for your opening remarks and for hosting this webinar. Next, let's welcome Mr. Li Zhanwen, the Senior Vice President of Mandarin Group, the organizer of this webinar. Please shift to the camera for Mr. Li.
Vice Chairperson Ho Yan, Deputy Director Zhang Jiang, distinguished medical engineering experts from Italy, the USA, and other countries around the world, ladies and gentlemen, good evening, good afternoon, or good morning. First of all, on behalf of Mindray, please allow me to extend the highest respect, the most heartfelt thanks, and the sincerest blessings to all the medical workers around the world fighting against COVID-19. At present, the novel coronavirus outbreak has become a serious global public health challenge. Although countries around the world are in different phases of fighting against the virus, and their medical systems and technology levels are diverse, we firmly believe that openness, sharing, and collaboration are key for us to defeat the pandemic. As the first country affected by COVID-19, China has accumulated much experience and effective method in combating the coronavirus. We hope to make a contribution to the international community for maintaining global health security by sharing our experiences and best practices. A few days ago, based on our efforts in combating the coronavirus, the National Health Commission of China, NHC, summarized Chinese solution, in which NHC shares China's experiences in multiple aspects, from epidemic prevention and control, diagnosis and treatment, to material support, and so on. As one of the leading medical equipment suppliers in China market, Mindray has made positive contributions to epidemic tackling in diagnosis, treatment, and material support. We extensively mobilize our employees and our upstream and downstream partners to take the lead in work resumption on the second day of Chinese Spring Festival holiday, and immediately delivered nearly 3,000 medical devices to Huoxingshan Hospital and Leishanshan Hospital, the two designated hospitals for COVID-19 case treatment in Wuhan, and then delivered more than 50,000 units to the hospitals across China designated for coronavirus case cure. Mindray is also planning to deliver more than 10,000 devices to Italy in near future and provide more equipment and solutions to countries around the world. Under the background of worldwide epidemic prevention, to fulfill the urgent and special demands, Mindray is capable of providing, with one-stop service, nearly 70% of the devices required by the infectious disease hospitals, covering the core departments such as clinical laboratory, ICU, emergency department, and medical imaging department. With its products and services, Mindray offers powerful support to hospitals for their overall configuration and standardized equipment management. The intelligentized and easy-use equipment of Mindray help to improve the efficiency of medical staff and shorten the training time. The devices featuring automation and being easy for disinfection also help to reduce nosocomial infection. The pandemic situation changes rapidly, and different medical ecology in various countries will continue to affect the evolution of the epidemic. Therefore, the Chinese solution shared today will also keep progressing into European solution and global solution. As a medical device and solution supplier, Mindray has been respecting the diverse conditions of each country in the world. It will focus on closer communication and collaboration and try to deliver the supplies most urgently needed in the most effective and optimized way. Mindray will continue to make contribution for global solution in the aspects of material support, diagnosis, and treatment. At last, I wish this global webinar a great success, and I wish we will win the war against COVID-19 as soon as possible. I wish all the present experts to take care of yourselves. Thank you all.
Thank you, Mr. Lee. We'd like to take this chance to express our appreciation of the contributions Mandarin has made so far for the epidemic containment in China. Also, we hope global practice will be created based on the Chinese practice and the best practice from other countries as well. Well, here comes the experience and practice sharing. Let's welcome the leaders of clinical engineering teams from the front lines of pandemic combat to share with their experience and feelings. The first speaker is Dr. Zhang Qiang, the Vice President of Wuhan Union Hospital, Tongji Medical College. Please shift to the camera to Dr. Zhang.
Dear Medical Engineering Fellows, good evening or good day. I'm Zhang Qiang from Wuhan, Hubei. Today, I'd like to communicate with you on the technical support issues of medical equipment in the epidemic. Wuhan Union Hospital, founded in 1866, consisted of 3 campuses and with 5,000 beds in total, is one of the largest general hospitals in Wuhan and even in Hubei province. Due to the outbreak of COVID-19 epidemic, apart from the main campus, Wuhan Union Hospital successfully turned the other 2 campuses into designated hospitals for treatment of severe cases of COVID-19. In addition, the hospital undertook the management and treatment of 2 mobile cabin hospitals for the treatment of mild and moderate cases. In total, more than 2,700 medical staff of Wuhan Union Hospital have participated in the fighting against the epidemic. Wuhan Union Hospital faced a shortage of protective materials due to the unexpected outbreak of the coronavirus. To curb the spread of the coronavirus and protect the safety of critical medical staff, the hospital immediately established a temporary material support command and initiated the emergency system, including applying for government material dispatchment, procurement of emergency supplies, and calling for social donations. Equipment, consumables, medicines, and other supplies in need were allocated through unified command. The hospitals tried its best to keep the supply channel clear, sought the materials to make it convenient for management, and dispatch materials in a centralized way to fully satisfy equipment requirements. For protective material configuration, the first thing is to ensure the quantity of supply. In the early stage, due to the shortage of medical protective clothing, masks, and other protective supplies, almost every ward had been reporting a shortage. There had been a big gap between daily consumption and supply. Therefore, we had to ensure a basic amount of the protective materials. In addition to actively contact with various channels for supplies, the hospital implemented accurate supplies. The list of protective materials required for critical practices, including the number of clinical staff on duty, as well as the tasks they undertook, was asked to be submitted once a day. Based on the corresponding risk levels in the different wards, we provided categorized supplies. A classification instruction of medical protective materials was worked out to ensure the safety of medical personnel who directly contacted with patients. On the other hand, we should ensure the quality of protective equipment to avoid the infection risk of medical staff, especially the donated protective equipment. Most of the donors are caring people without medical professional backgrounds who know little about protective equipment. Some of the donated materials were not for medical applications or failed to meet the required protection standards. Therefore, we set up an appraisal team for donated materials. The specialized personnel was sent to study the registration certificates and utilization standards of various protective materials from China or overseas. According to relevant requirement of the country and the actual situation of the hospital, we set up an identification standard of protective materials to control the quality of all the materials. In a short period of time, our hospital turned 2 campuses into designated hospitals for severe case treatment. The West Campus of Wuhan Union Hospital has opened a total of 12 treatment wards, and the Tumor Center has opened a total of 14 wards. The following are the main difficulties we were facing. First, serious shortage of major treatment equipment. The number of COVID-19 patients soared in a short period of time, whilst the factories stopped operation during the traditional Chinese New Year holiday. As a result, the manufacturers could not supply relevant treatment equipment in time, which led to a serious shortage. Second, logistics and transportation personnel were also in shortage. Due to traffic lockdown, it was hard to achieve normal transportation. We needed to pick up some goods by ourselves, which further aggravated the shortage of clinical engineering staff. Third, there was a lack of technical support personnel. The equipment we have purchased and received were from different brands and models. Due to the lockdown of Wuhan city, most of the technical personnel of equipment manufacturers outside Wuhan could not come to our hospital for assistance in equipment installation, training, and maintenance, which posed growing workload of technical support to the clinical engineers in our hospital. In addition, we also met many other problems, like the oxygen support equipment failed to generate required oxygen flow. Since most of the patients with COVID-19 needed to use a ventilator for special oxygen treatment, the demand for oxygen grew even as high as dozens of times of the normal demand, while some ICUs were converted from ordinary wards, whose oxygen supply system could not meet the actual demand, which caused a drop of oxygen pressure and low flow rate. In addition, the ward saw serious shortage of disinfection equipment. In order to reduce the infection risk of medical personnel in the wards, a large number of disinfection equipment needed to be configured. Life support equipment, such as ventilators and ECOM, were also in shortage. The following are the countermeasures we've taken. First, multi-channel synchronous medical equipment configuration. We asked for assistance from the government and authorities and requested an urgent allocation of medical equipment. We conducted business negotiations, consultations, and purchases through the internet and raised donations from the public. Second, organizing volunteers to assist in logistics and delivery of medical devices. We recruited volunteers from the public for the work of medical devices transportation. Third, establishing a technical support team to ensure that the equipment were put into use in a timely manner. The medical engineering department has set up engineering technical groups according to different equipment categories, such as respiratory units and disinfection equipment groups, to complete the installation, commissioning, clinical training, and maintenance of corresponding equipment. Fourth, online communication with the manufacturer's engineers to get technical support from the manufacturers. During the epidemic period, technical support work of more than 6,000 medical devices was completed. We allocated different kinds of disinfection equipment for different usages. For the disinfection of hospital beds, bed sheets, mattresses, pillows, clothes, etc., we allocated 2 bed unit disinfection machines for each ward. To disinfect the environment of wards, we allocated a plasma air disinfection machine for each contaminated space or ward, with personnel staying in it for long term, where humans and machines could coexist. We used an ultraviolet disinfection machine or an ozone disinfection machine for each contaminated space without personnel staying in it for long term. Then, after the patient was transferred out of the hospital or discharged, we performed the thorough disinfection for the room, with terminal disinfection robots, hydrogen peroxide robots, etc., and equipped one of them for each ward. For the guarantee of oxygen devices, we complemented the central oxygen supply system with oxygen cylinders and oxygen generators, etc., and replaced liquid oxygen tanks and vaporizers of the central oxygen supply system with larger ones to increase the flow rate of center oxygen supply system. Secondly, in response to the needs of patients undergoing oxygen inhalation in the wards, 5 oxygen generators were provided for each ward. In response to the extensive use of ventilators, 5 40-liter oxygen cylinders were provided for each ward as spares. For the configuration of medical ventilators, we equipped a certain number of multifunctional ventilators compatible with both non-invasive and invasive operations, as well as respiration and treatment in each ward, making it convenient for timely adjustment and use according to the changes of patient symptom. Non-invasive ventilators used for critical patients should integrate the function of accessing high-pressure oxygen source and the function of monitoring the concentration of output oxygen, which were adjustable. According to the actual needs of clinical treatment, we have developed reference standards for the configuration of various types of ventilators in ICUs, wards for severe cases, general wards and mobile cabin hospitals, etc., in the bid to fulfill the demands of treatment by improving the efficiency of equipment use. Issues and difficulties of emergency equipment support in mobile cabin hospitals. Firstly, issues and difficulties we met in mobile cabin hospitals were mainly those related to mild and moderate cases. These patients were admitted in accordance with the requirements of leaving no COVID-19 patients unattended. Secondly, mobile cabin hospitals lacked the necessary facilities and equipment for medical activities, as they were temporarily transformed from public facilities, such as exhibition halls and gymnasiums. In response to this situation, we have formulated reference standards for equipment configuration in mobile cabin hospitals based on patients' conditions and equipped the hospitals with required medical equipment. Thirdly, we provided oxygen supply to patients in need with oxygen cylinders and oxygen generators. We also coordinated with the manufacturers for emergency deployment of mobile onboard CT, mobile DR, and other equipment to conduct basic image examinations. The key points of emergency support. Firstly, material support must be put in place, including protective materials, oxygen supply devices, and disinfection equipment, ECOM, and other equipment. Secondly, the training before use is very important. Since many medical workers come from various departments and have never used some of the equipment, conducting training for them is very important before they enter in the isolation wards or the cabin hospitals. Thirdly, the configuration of equipment consumables is also very important, and the supply should be ensured. Fourthly, due to the protection requirements of the isolation wards, it is very inconvenient for clinical engineers to enter the isolation areas or the cabins for maintenance, entailing preventive maintenance of the equipment to reduce temporary failures. So far, the epidemic has been basically curbed in Wuhan. We are doing some emergency response-related work. For example, inviting experts to compile relevant consensus and guidelines, such as the guidelines for the construction and equipping of emergency mobile cabin hospitals, and the guideline for stockpile and management of hospital emergency supplies. In addition, we're discussing the establishment of material reserves and information bases for public health emergencies and cooperation with universities for innovative research and development of medical equipment in response to public health emergencies. In the end, I hope all the colleagues pay attention to self-protection. I believe we can overcome the difficulties, and we will be the winner. Thank you.
Thank you very much, Dr. Zhang. To reduce the spread of the coronavirus, your city, Wuhan, was totally locked down for exactly 76 days, and it was just reopened the day before yesterday. Your story is very encouraging, and your team is deserved to be the heroes of the nation. The next speaker is Ms. Chen Hongwen, the Director of Clinical Engineering Department of Nanfang Hospital, Southern Medical University. Please shift to the camera for Director Chen.
Ladies and gentlemen, fellow clinical engineers, good evening, good afternoon, or good morning. I'm Chen Hongwen from the Equipment and Instrument Department of Nanfang Hospital, Guangzhou, China. I'd like to share with you what responses should the clinical engineers make for combating COVID-19. In recent months, the COVID-19 has almost raged throughout the world. As the virus is ravaging and medical workers are making arduous efforts to fight against the pandemic and save patients' lives, what should we clinical engineers do? Strategy 1. We must estimate in advance and make accurate assessment. Fever clinics have been established in all of the large Grade 3 Level A hospitals in China. During the outbreak of COVID-19, fever clinics function as the outposts for triage and pre-screening, turning them into high-risk areas. Before using them for triage and pre-screening, clinical engineers must estimate in advance the availability of protective materials and equipment for protection, diagnosis, and emergency use that might be needed in fever clinics. Then they should get materials ready, install, and calibrate equipment to make sure doctors and care workers can use them properly. Meanwhile, we must work together with the Epidemic Prevention and Control Command Department to make a list of protective materials and equipment needed during the outbreak to ensure that through emergency procurement, centralized allotment within hospitals, and accepting donations and various other means, that we can have the supplies handy. Strategy 2. We must stringently control the quality of supplies and well protect frontline medical staff. As a Chinese saying goes, provisions should be arranged before an army is mobilized. Clinical engineers should act as provision officers of hospitals. We should not only provide the materials and equipment required by medical staff, but also make sure the supplies are safe, reliable, and effective for clinical applications. Therefore, we must conduct quality inspection for the supplies to ensure usability. In the case of extreme shortage of materials, which is quite possible, as many materials are undersupplied during the pandemic, we clinical engineers should make the fullest use of our expertise and techniques and available materials to produce some simple equipment and instruments in urgent need by clinical staff which do not require CFDA certification. For example, mobile ultraviolet disinfection devices that are used to disinfect high-risk wards or public spaces to prevent cross-infection. In addition, we should apply emerging technologies such as robotics in clinical practices. For example, use food delivery robots, logistics robots, intelligent disinfection robots, etc., to reduce workloads and exposure risks of medics working on the front line. Strategy 3. We must provide standardized trainings to drive home the basic prevention and control processes. As everyone knows, COVID-19 is highly contagious. In order to prevent cross-infection in a hospital, equipment cleansing and disinfection must be conducted strictly. In light of various kinds of equipment, clinical engineers should formulate guidelines for equipment cleansing and disinfection together with nosocomial infection experts. We must train and guide medical workers to cleanse and disinfect the equipment as necessary. Here, we are only able to share some disinfection measures for your reference due to time limit and the vastness of the topic. Strategy 4. We must speed up the use of mobile medical equipment. Converting exhibition venues into makeshift hospitals, aka mobile cabin hospitals, is an effective measure adopted by China to deal with the pandemic. In the same way, large equipment such as mobile CT scan cabins and mobile DRs can be turned into mobile medical facilities, given that the cockpits and the equipment are installed in large containers which can be quickly moved to locations wherever they are needed. In doing so, we don't need to remodel the existing facilities so that it's flexible enough for hospitals to provide the most suitable and convenient access for patients to avoid cross-infection. Also, specific equipment will be used for specific purposes, which proves to be efficient in controlling the pandemic. The outbreak of the pandemic leaves clinical engineers with many thoughts. What should we do if a public health emergency occurs in the future? And how should we do it so that frontline medical staff can be better protected while throwing themselves into the fight? First, the severe pandemic laid bare the issue of insufficient supply of medical equipment and materials. In the future, how to establish an efficient medical material stockpile system. For instance, whether to create an inventory for emergency materials and equipment, or to build a collaboration mechanism consisting of regional healthcare alliances or healthcare communities to share treatment data and medical resources. Will such a centralized and multi-tiered mechanism be a boon to the allocation of materials and equipment? Secondly, the emergency equipment that are used come in assorted types and models, and frontline healthcare workers come from hospitals and different provinces with various professional background. How to ensure they can quickly get a hand of the equipment? How to establish an efficient training system is also what we should do next. Thirdly, speaking of robotics and R&D of Internet of Things, in high-risk environment, they can be leveraged to replace medical staff to do some work within their capabilities and reduce occupational exposure of these people. During the epidemic, can we use IoT, wearables, and all kinds of robots in different scenarios? Finally, how to organize the logistics of moving emergency materials and equipment around and ensure safety in use? Can we standardize management protocols to guarantee safety and quality of the equipment when they are used in such special circumstances? In the interest of time, I have to wrap up hastily. COVID-19 is the common foe of mankind, and we have to respond to it with joint efforts. Please feel free to let me know if there's anything that misses a point in my presentation. Thank you.
Thanks a lot for your sharing, Ms. Chen. The four strategies you mentioned, we as clinical engineers fighting for the COVID-19 are quite impressive. Next, let's welcome our American guest speaker, Mr. Michael Busdicker from ACCE to tell his story. Program Director, please shift the camera for Mr. Busdicker.
Can you see my screen? Okay. Thank you very much for the opportunity to be here. I'd like to thank the American College of Clinical Engineering for allowing me the opportunity to present here, as well as all of my counterparts across the world. This is a time we haven't seen in the past, and an opportunity for us to share information with each other so that we can prepare and do the best we can to treat our patients across the country. My name is Mike Busdicker. I'm the System Director of Clinical Engineering for Intermountain Healthcare, and we are located in the state of Utah, based out of Salt Lake City, Utah. We actually have about 23 hospitals and 200 plus clinics across Utah, Idaho, and Nevada. We employ about 40,000 caregivers throughout our system. 112 of those are healthcare technology management caregivers, or those working frontline with the equipment. We are a shared service model, so we have central-based hospital operations with hospital-based technicians as well. So we are currently in the state of Utah, seeing that we're in the very beginning stages of the
Excuse me, Mike.
Yes.
Excuse me, Mike. Yeah, we can't see your shared screen.
Oh.
Yeah.
Okay. Let me try this again then. Can you see it now?
Yeah, there we go. Good.
Okay.
Thank you.
Now we're good. Now we're good to go. Okay. So again, here in Utah, we're at the very beginning, what we think at the very beginning of the pandemic. We have tested over 38,000 people in the state. We're approaching 2,000 positive cases at this time. We're seeing about a 10% admission rate of those that are testing positive. Our projected peak here in Utah is sometime around May or June based on the numbers that we're putting in and what we're seeing. So at this point, like I said, we're very early in the stages of preparing. We've utilized a lot of the data and information that's being shared from those that have been through the pandemic and are seeing the increased amount of cases. So we're utilizing that data and information to help us as we progress through. I would say, let me see if I can get this. Now I need to do is get it to advance. Okay, so the next thing, one of the first things that we've done in the state of Utah, and I know it's here probably unique in the United States with things, but we've established an incident command and control at the state, local levels. So at the state level, numbers are reported. We report them out from the hospital facilities and into the local health departments, and then they're reported to the state at that point. And one of the things we wanted to make sure is that we have healthcare representation on that incident command center. Not just healthcare representatives, but those that can represent clinical engineering and the equipment that we're utilizing to treat the patients. So we want to make sure that there's one source for document control and data submission. So all of the information from our healthcare facilities, along with the healthcare institutions across our state as well, that data and information is compiled at the local facility, taken by those healthcare representatives, and then reported at the state level, one source of truth. And we want to make sure, again, that medical equipment and consumables numbers are reported to the state so they know where we stand with our medical equipment, the critical equipment that we have, along with the consumables to be able to support that equipment and the patient load that's coming in. So at Intermountain Healthcare, we have the same thing. We've developed an incident command center. We've got incident command centers in each one of our hospitals. They gather the data and information that they need. It's communicated up to the incident command at the corporate level, where we've got subgroups that are established, including the logistics team, and that's where clinical engineering is involved, is with that logistics team, and then setting on meetings with clinical personnel as needed when we talk about bed expansion and the availability of ventilators, availability of infusion pumps and other critical devices that we've designated throughout the source. So again, those subgroup chiefs are the one source of truth for the organization to be able to report information up through the state. We have routine daily meetings. So every morning, I'm in meetings all morning long on these subcommittees and groups. We're looking at how many ventilators we have, how many are in use, how many are currently down, and our technicians or our engineers are actually working on those to get those up, how many we're receiving in from organizations like local colleges and universities that are loaning us ventilators that are out of their respiratory program, and we're making sure as those come into the system that they're processed through clinical engineering first so that we can ensure that they're fully functional and operational, as well as having the consumables and the patient circuits that are required for them as well. The other thing that we do is I have daily healthcare technology management reports that are funneled to me from my directors. So my directors are giving me information every day on how many infusion pumps are down, how many ventilators are down, what are the status of those ventilators, how involved are they in the expansion process for ICUs or converting pediatric units to adult units, as well as our own internal staffing. How are our staff doing within our facilities? Do we have enough staff? Are we seeing our staff become infected and not available to work within our hospitals? So we're looking at our staffing on the clinical engineering side as well. Again, those daily reports, internal versus external. So we're looking at from a statewide perspective, we're looking at healthcare facility occupancy, ventilator reporting, other critical equipment. So we're gathering that data and information at a state level by healthcare systems. So whether we've got Intermountain Healthcare is reporting all of our numbers up to the state. University of Utah, other healthcare systems within the state are reporting all of the information, so we have an idea statewide of what we have available, what's in use, and what is going on within our systems. And then the same thing from the internal perspective. So my staff has the ability to look at our occupancy reports and know how many open beds do we have, and of those open beds, how many of them are critical care, COVID specific patients? What are we looking at in our expansion areas, as well as, again, the numbers of ventilators that we've got out there? How many of them are in use, and how many are in use on COVID patients in comparison to standard patient care? How many of those ventilators are down, and what's the status with those? And then we look at our daily surge plans. What are we anticipating coming into our facilities every day? So we talk about that in the morning. We look at what our surge plans are. Where are we going to put those patients? If we need to divert them, where are we going to divert them to? And then we talk about the equipment movement and the ICU expansions. So we've expanded 75 beds capability for ICU that are COVID specific, and we look at, do we have the nurse call systems, the monitors, the ventilators, and equipment to support those expansions, as well as how are we going to move that equipment? How are we going to get it from facility to facility, or how are we going to get it from our staging areas that we have and move that equipment into those hospitals and areas, and how are we going to get them to those departments that need it? And lastly, a lot of the things that we're working on now include our business continuity and surge planning. So we're looking at things like our own staff. So we've got a lot of staff, not a lot of staff, but I've got staff that are analysts that are looking at data and information all the time. Our admin support. We're looking at things like our parts and inventory person that does the coordination, and they don't really need to be on site. They can work remotely and stay in contact and continue to stay in contact with all of our clinical engineering personnel. And we want to make sure that they've got the tools and resources necessary for them to be able to work remotely and do it long term. Again, I talked about the loaner equipment. We make sure that from the front line that any donations that are coming in, any loaners that are coming in, all processed through clinical engineering first before they go out to any facilities. Typically, what we like to do with that is we move those as they come in. We stage them in clinical engineering. We test, operate, make sure they're ready to go, and then we stage them for deployment within clinical engineering instead of putting them out onto the floors to begin with. We move them as needed. We look at things like repurpose of equipment. So utilizing our anesthesia machines as ventilators, and ensuring that when we're looking at that we've got our anesthesia docs as well as our respiratory therapist involved in that process, so they know exactly what is required to be able to do that, as well as involving clinical engineering if we're going to move those systems or whatever we need to do to adapt them to ventilator function. Clinical engineering is involved on the front line, and we've got the experts there with us as well. And then I talked about the one source of truth, and that is going into the state levels. And if we need to request equipment from FEMA, which is the Federal Emergency Management, that has to come from the state level here in the U.S. And we make sure that we're part of that process, and we've got our peers across other healthcare systems that are involved in that process with us. We really emphasize equipment disinfection and sanitization. So any equipment that's coming out of or being staged for COVID treatment patients, as well as any equipment actually within our facilities that's going to clinical engineering for any type of repair, we make sure that all of that sanitization and disinfection is done before it comes into the shop, and then make sure that it's done prior to it going out of the shop. And our purchase requisitions, when we look at our standards across our system, what type of training do our staff need? So if we're buying something, requisitioning a piece of equipment or multiple pieces of equipment that are not standards within our facilities, what type of in-service or on-the-job training is going to be required for our clinical staff, as well as our clinical engineering people, to be able to support those. And do we have the consumables to be able to put that equipment in operation? It won't do us any good to get ventilators in to treat patients if we don't have the patient circuits or consumables that are required or needed with that equipment. So again, taking a look at that from top to bottom across the entire process. We want to make sure that our HTM caregivers, so our staff, have the proper PPE. One of the first things we did as we started preparing for this is we met with our staff and we talked about standard PPE use. And then we got a listing of how many of our staff across our system, from the clinical engineering perspective, are N95 fit tested. How many of them are PAPR trained? And so we've got that list. And if we need to send people into different isolation areas, we know who's been fit tested. We know who's been trained on the PAPRs. And those that are not, we need to do some just-in-time training for them so they've got the proper PPE as well. We want to make sure that we really look out for and take care of our staff. Our staff cannot support the facilities, keep the equipment up and running if they're not well. And so we need to look at the workload, our hours, our downtime, ensuring that they get some downtime, that they're supported from the corporate perspective so that they know that the work that they're doing is frontline work, no different than what our clinical caregivers are giving as well. So we want to take a look at that workload, and if we get into a situation from a staffing perspective that we're not able to support preventative maintenance on non-critical or non-life support equipment, then we'll start deferring those PMs and catch up later on with those, but making sure that we're focusing on that critical care life support equipment that is required and needed for our patients. And then continuity plans. We have put together continuity plans for our own internal department. So we're looking at, what if we hit staffing shortages? What are we going to do to share resources? What are our other outside resources that may be available to us, as well as our suppliers? So if we look at organizations that may be supporting us from a full service contract perspective, what if they run into shortages in our area? What are their continuity plans to continue to support us, whether it be from a service perspective or a parts perspective? So we've gathered those continuity plans for all of our outside suppliers, and we've got them in a central location so that we know that we can turn to those continuity plans and understand how our suppliers are going to continue to support service within our facilities. And then it's really looking at and understanding the worst case surge. So we look at that graph and we try to level the graph and not have that spike. But if it does occur, what are our plans? What are we going to put in place? Let's plan accordingly and understand what the worst case scenario is for our organization as well as for our state. Because although we may be competing healthcare systems within the state of Utah, we still have the same objective, and that's to ensure that our patients and those that we support in our communities are taken care of as best as possible. So we coordinate across healthcare systems and across personnel and understand what worst case is and how we can support each other. Thank you very much. I really appreciate the opportunity again to present. And like I said, here in Utah, we're at the beginning stages of this. So I really enjoy or really taking a lot of notes from those that have been through it. And we'll implement a lot of those practices here. So thank you again for the opportunity.
Thanks, Mr. Busdicker. So it seems many things, the clinical engineers and biomedical technicians, both in USA and China, doing the things are quite the same. But a few things you mentioned, such as repurpose equipment, use anesthesia machine as ventilator in the condition of ventilator shortage is not common in China. Thanks again, it's very impressive.
Thank you.
Now, the last speaker is Dr. Samantha Jacques from AMI, USA. Please shift the camera for Samantha.
Good afternoon, good morning, and good evening, wherever you are. Can you see my screen?
Yes.
Kingston? Wonderful. My name is Dr. Samantha Jacques. I'm the Vice President for Clinical Engineering at McLaren Health. So McLaren is currently in the state of Michigan. McLaren owns 14 hospitals across the state of Michigan, and we're a few weeks ahead of where Mike's team is in Utah. So currently, Michigan is considered a hotspot. Detroit has the third largest number of cases, and Michigan, again, is the third largest state after New York and New Jersey to have cases. So currently, as of this morning, we have 21,000 COVID cases across the state, and we've had 1,000 deaths to date. This puts us in the COVID curve somewhere near the peak. We're getting to the point where we're seeing volumes finally start to level, and we're crossing our fingers that we've reached the peak and we're ready to go on the downside of the slope. It has been quite challenging, and I do appreciate all the rest of the speakers in this webinar and the opportunity to provide our insights. As we are a little bit earlier in the US in the curve, I'm happy to share any insights that I have as to how our health system has responded to the COVID crisis. So as many of my colleagues have already discussed, forecasting equipment needs is probably the most important thing you can do while you're preparing for COVID. As many health systems have across the nation and across the world, we've looked at setting up non-ICU space to house ICU patients. We've transitioned all kinds of different units into ICU space, and that requires all kinds of equipment, including beds and pumps and IV poles. This picture here is some high flow oxygen setups, ventilators. We've also taken steps in our health system to look at other equipment and use those as ventilators. As Mike alluded to, the use of anesthesia machines as ventilators is possible, but before our health system decided to do that tactic, we went ahead and set up test lungs, and we trained patients, trained providers and respiratory therapists to optimize what that looks like. Currently within our systems, we're not using anesthesia machines as ventilators. They are still backup, as we have enough ventilators to date, thanks to FEMA and the amount of equipment we've gotten from them. However, we still have this in our arsenal because we're unsure as to how many net new patients we are going to get. I will tell you the regulatory and preventative maintenance plans are also very important. So obviously, if your state or your area hasn't been hit, please take this time to go ahead and make sure all your equipment is in functioning order and getting them up to speed as quickly as possible. You're going to be looking for equipment in any place that you can, and having any broken or downed equipment isn't helpful at this time. We've also, in our state, paused our regulatory PM program, obviously because most of our equipment is currently in use on patients. And so deferring that preventative maintenance to a later date is an option. So please be aware, document everything that you need to be in compliance with your regulatory partners. I will tell you from an equipment lessons learned, going through this process, we did a ton of planning and had a huge list of equipment to help us transition our non-ICU space into ICU space. The one challenge that we've had continually, and it was prior to COVID as well, is feeding pumps. So those patients that are intubated and on ventilators obviously need to be fed. And so we acquired some additional feeding pumps, but we've had issues finding the disposables related to those feeding pumps. And so while you're putting your plans together on expanding your ICU population, I highly encourage you to become very close to your supply chain partners, because understanding what limitations you have from both an equipment side and a disposable side is very important. We've created backup plans on how to feed patients using gravity feeding and other methodologies, but you will run into problems and you need to be able to adapt on the fly to exactly what's happening in each one of your hospitals. The other challenge that we've had in our system is obviously the changing recommendations. So sometimes it feels like there's new CDC guidelines on a daily basis, and keeping up with those and changing your daily processes to adapt to those is very challenging. In one area, the N95 sterilization plan has been quite challenging. We've done everything from sterilize them in sterilizers to the UV light and trying to figure out what works best. Please go ahead and continue to utilize any methodology you can from an adaptation perspective to continue to keep your caregivers and your staff safe. So I will tell you from a staffing perspective, we have implemented in some of my hospitals an alternative staffing plan. So obviously if your staff is coming in and repairing medical equipment as a group on a Monday through Friday, 8 to 5 kind of basis, they're all going to be exposed at the same time, and you have a high likelihood of all of them going out at the same time. We've implemented a staffing plan that brings in 2 different teams on 2 different schedules. So Monday, Wednesday, and Friday, you might see one set of technicians. Tuesday, Thursday, and Saturday, you'll see a different set of technicians. And that allows us to mitigate the risk of staff going out on COVID. And if you do become infected, one of your staff members, you're not spreading it to your entire team. I realize that's a challenge in some locations, but becoming flexible with your staffing plan and thinking through what will happen if your staff have COVID and you're no longer able to support the hospital is a very important thing to do. Also during this time, I'll tell you, it's very difficult to keep your staff motivated and provide them a safe place, safe working conditions. Please continue to communicate often to your staff. They want an area to go ahead and raise their concerns. You need to be able to adapt to their needs. And you need to be able to ensure that your staff stays motivated. This is a marathon for a lot of us, and we're 3 weeks into a really rough marathon at this point. We've got another 3 to 4 weeks on the back end. Those states that still haven't even started to see a pickup or 3 or 4 weeks even away from the peak, it is a very long trek between now and then. And so please continue to try and keep your staff motivated, continue to communicate with them, and be upfront about what's going on with them. Similar to what Mike talked about, our hospital system also has daily huddles from a leadership perspective. We continually communicate to ensure equipment, staff, supplies, and current status of where everything it is. You need to continue to have those communications and truly be open to sharing data across your health system and across departments within your health system to ensure that you're responding appropriately. Finally, I'll say, I've alluded to it, but alignment with other departments in your hospital is essential. Supply chain has everything you need from a disposable perspective. And so any piece of equipment that we have generally has disposables. And so you need to understand from them what they can get, what they can't get, and that'll change what equipment that you're actually deploying in the field. You'll also need to be very close with your emergency management team. Mike alluded to this as well. You need to be locked into your emergency management groups because they're the ones that communicate with the state and the national stockpile groups and FEMA to allocate the equipment and supplies that you need. Respiratory therapy obviously is very important. You need to go ahead and understand with them what their needs are. We've seen changes throughout our entire peak on the type of patients that we're seeing. And so we've moved from a lot of invasive ventilators. We're now seeing more BiPAPs and high volume airflow as support. And so staying in tune with your respiratory therapy group to see what they're seeing and help them understand what equipment they need to support their patients. Obviously then IT, anything that we're implementing, obviously a lot of our hospital systems are spinning up a whole lot more telehealth to have remote visits. As you're moving into new nursing units, you may need nurse call or other integrations to go ahead and optimize your nursing workflow. So please stay close with your IT friends as well. Lighting up ports, getting wireless in places that don't necessarily have it is a challenge. And so continuing to communicate helps all of us get through this. And then I'm going to tell you webinars like these, as well as message boards, Amy has one, or communication with your other hospitals is essential at this time. I've been in close contact with my counterparts and other health systems in Michigan. What do they see? We've been able to share equipment across health systems. This is not a time for healthcare technology management to compete health system against health system. It's really a time for us to work together and help each other get through this crisis. So again, Zenkun, thank you for the time. Thank you for coordinating all of this wonderful webinar, and I will turn it back to you. And great thanks to all of our healthcare providers on the front line, keeping all of our patients safe across the world.
Thank you very much, Sam. As one of the most welcomed guest speakers of the CEHTM training in China, called Flying Over the Hump a few years ago, this name, Flying Over the Hump, is named in memory of the collaboration between China and the US during the wartime. Sam is an old friend of Chinese CE community. And just like Sam just said, working together, we sincerely wish the global CE community will unite as one and fly over the hump again. And now, here comes the panel discussion and Q&A session. Apart from the 4 experts who shared their experience with us just now, Dr. Ernesto Iadanza from Italy will join the panel discussion too. Dr. Iadanza, would you please brief us the current challenges and the situation Italy clinical engineering professionals are facing now? Please. Iadanza, you needed to open your microphone. Sure,
okay, yeah. Can you hear me now? Mm-hmm. So again, thank you so much for inviting me here. I'm very happy, and I was really delighted for the interesting presentations that I couldn't hear right now. So I'm here representing both the International Federation for Medical and Biological Engineering, HTA division, which I chair, and the AIIC, the Italian Association of Clinical Engineers. Well, we have been looking at the starting of COVID-19 outbreak in China with concern and distress. A few months ago, not far from my hometown in Florence, I live in Florence, there is one of the largest Chinese communities of the whole Europe, which is in Prato. Well, they started applying measures of containment, such as self-isolation and voluntary quarantine, back in January. And we have learned a lot also by their videos, for example, on social media about correct use of PPEs and also early measures for prevention and containment. So looking at the images from the most important Chinese cities in lockdown, it was heartbreaking for us. And nevertheless, it was, I would say, not enough to trigger a proper early disaster preparedness plan. So there have been few weeks of delay that I think could have been better exploited. And the same happened to other countries when they looked at Italy. So when the outbreak hit hard Italy, starting from Lombardy and Veneto, 2 regions in the northern part of Italy, well, the role of clinical engineers immediately became crucial, adapting existing wards to become ICUs, designing and realizing new hospitals from scratch, procuring new equipment, repairing all the existing devices under maintenance, informing the decision makers and the population like never before via press conferences and all kind of meetings, preparing technical specifications for national and for local tenders and auctions, training new CE colleagues and healthcare staff, certifying new devices, assessing new technologies. So these are just some of the activities that are very suitable for a thorough disaster preparedness program. Well, in terms of lessons learned, information and communication technologies are vital for knowledge sharing. We are today in a great conference which would never be possible without these infrastructures that we have, as well as for sustaining social relationships. And this is also something every one of us is experiencing in these days. This time they are coping well and they're doing great, let's say, but at least on a large scale. But nevertheless, a plan B is very much needed for this critical infrastructure. Total intensive care beds in our hospitals have been cut by a factor of 5, I would say, starting from the 80s. And this happened for many reasons, like the reduced length of stay and the minimally invasive technologies. We struggled in these days to double the overall amount of ICU beds in Italy from about 5,000 to about 10,000. Well, a proper disaster preparedness plan is needed for the future, leveraging on new flexible systemic approaches. Today we need ICUs. Next time it might be ORs, or it might be psychiatric departments, or who knows what. So a systemic approach able to react in few hours to unforeseen worldwide changes is needed. And lastly, the network of professionals, like testified today here, like Samantha was mentioning before, scaled up in the last 5-10 years thanks to international conferences, to ICT social groups, international organizations, like many of the associations who are represented here today, and collaboration with the World Health Organization, WHO, but also scientific journals, magazine, etc. These are resources that in these days are more valuable than diamonds, I would say. Fostering all possible exchanges between universities and national associations should be our first commitment for the future. Thank you.
Okay, thank you, Ernesto. And we sincerely hope the situation in Italy will be improved very soon. And now we begin to have a discussion for many questions. Based on some common questions our audience interested, we choose some questions for discussion. The first one is about ventilators. There are two parts of this question. The first half part of the question is, has anyone implemented remote ventilator control? Was it successful? Okay, who goes first? Sam, any comments?
Sure, I'll comment. We have not implemented remote ventilator control. The only things that we've done outside the patient rooms is we've moved the pumps, the infusion pumps outside the patient rooms to allow less going in and out of the patient rooms and using PPE from the nurses to just go in to touch the pumps. We've also changed some of the programming of our nurse call system so that nurses can cancel nurse call alarms from outside the room to, again, mitigate how many times the nurses go in and out. But I'm sorry to say, Zhang, we have not done any remote ventilator work.
And seems it's similar in China. I asked many of my colleagues, and I haven't heard any hospital here in China using the remote ventilator control. Yeah. Mike, you have any comments on this topic?
So I read a little bit of information about it, and I've seen that Berkeley, along with Medtronic, is doing some testing along those lines of the ability for a respiratory therapist to be able to monitor, be able to control ventilators from outside the room, which would save them from having to get all of the PPE and equipment necessary, and would really maybe protect them a little more from having to go into the room to do that. Now, what I found is in talking with some of our respiratory therapists here, they're very, very concerned about that capability. They're not sure that that standing outside the room and controlling a ventilator through an app on a phone is something that they want to move into. But I know that there is some testing going on right now between Berkeley and Medtronic on that process.
Okay, thank you. So the second half of the first question about ventilators is, any comments on a single ventilator for multiple patient needs? Sam?
Sure. So we tested the ability to do multiple patients on a single ventilator, and we have all the equipment to do it. However, our respiratory therapists are concerned at the high PEEP that most of the patients need when they're on ventilator support. And so matching 2 or more patients that need the same amount of support is very difficult. We have not implemented it, but I will tell you from a planning perspective, we did plan for it and we did test for it and have everything we need should we ever need to implement it. But I would really highly recommend that you discuss this with your respiratory therapists because there are upsides and downsides to using a ventilator for multiple patients.
So
Okay. Yeah, go ahead.
Well, if I could, as well. So we've done the same thing at Intermountain Healthcare. So we have tested the potential to use ventilators for multiple patients. We 3D printed the expansion valves, what we're calling the expansion valves, to be able to do that. And what we did was we, in the clinical engineering department, we assisted in that process, but we really involved the respiratory therapist in that process. So we had them there when we were doing all the testing. And I think some of the things that they found is that if you're going to move to that direction, one of the things that they need to do is to evaluate the patient needs and the acuity of the patient, because if you're going to connect more than one patient to the ventilator, they need to be very similar in their needs for the ventilation.
Okay, let's move on. The second one is, how did you continue to motivate staff during this crisis, during this very difficult time? Anyone volunteer to answer?
So again, I think in looking at motivation of staff is really keeping them informed on what's going on so that they know, there's a lot of stuff going on out there about thanking frontline healthcare providers, and they focus on nurses and doctors. And we need to make sure that our staff understands, as well as leadership within our organizations understand, that the clinical engineering technicians and those that are out there on the front lines, they are frontline staff as well. And they're just as important as the clinical caregivers within the facilities as well. So really communicating that information to our staff, understanding so that they understand how important they are in the entire process of treating these patients and providing care.
I agree 100% with Mike. The other thing that we've done, because Michigan went into a shelter-in-place state, all of our schools are closed. Obviously, staff have issues trying to get childcare for their families. We've been very flexible with staffing hours and trying to support them. Historically, obviously, we'd like to have a manager on site when we have staff on site. We've gone to 24-hour staffing, so if staff want to work a third shift and be home with their families during the day, if they want to work 3 12s instead of 4 10s, 5 10s, we've been very flexible as to what that looked like. And that's a person by person kind of conversation. We also are very grateful to them for what they're doing. And we've allowed them to take that work that we're doing and really showcase it within the hospitals. And so very similar to what Mike was saying, right? There are a lot of groups that are providing great support for nurses and doctors. Our nurses and doctors have turned around and provided great support for our support staff. And so if you can find that within your hospitals to support each other, it's been very helpful in motivating our staff.
Thank you. Ernesto, would you please add some special opinion on this? As we know, you are a great singer. Maybe singing is a very good way of motivation. Huh?
Mm-hmm. Yeah, sure. Well, I have one question that is the following. So in Italy, we have no requirement that formally has been waived by no laws for medical equipment. And clinical engineers are often called to admit a new piece of equipment. For example, it could be a pulmonary ventilator or missing some requirement. So, for example, with a user manual written in a foreign language or other, we call them violations to the EU rules for CE marking. So what I would like to know, maybe from the four of you, is are there any legislative simplifications in place in your countries, for at least for critical equipment?
Thank you. Who answer first?
So here in the, I'm sorry. So here in the U.S., you know, we've got the Center for Medicaid, Medicare Services, who really drives things from a federal perspective. So we do have our inspection agencies like the Joint Commission or DNV that do our survey and accreditation inspections in our hospitals. And in order to move away from standard regulatory requirements for preventative maintenance or inspection of equipment, there's a waiver that's required through CMS, but getting that waiver is not the easiest thing in the world to do. The state can apply for one for an overall general waiver that can include the medical equipment piece in there, but again, it's not the easiest thing to get. What we're doing right now, because we're on the front end of this, is that we're requiring our staff to continue with the preventative maintenance on everything, equipment check-in on everything. But as we start to progress through the pandemic and we start to see that surge, that's where we've written into our continuity plans, and we've got organizational leadership all the way to the top that says, if we get into this situation, we can defer the PMs on non-life support, non-critical equipment, and we will deal with the regulatory agencies after the fact, because it's more important to focus on the equipment that is required for treatment of these patients, as well as if we've got new equipment coming in, just ensuring that it's functioning the way that it's supposed to be, and we got the consumables, and then getting it to the floors or getting it to the clinical staff that are treating the patients. So we've got that approval process across the organization all the way up to the CEO. But we have submitted for the 1135 waiver from CMS, and we're waiting for that paperwork to come through. But in the meantime, we have put those continuity plans in place.
Okay, thank you. And another question for discussion following the previous question Ernesto put forward. The question is there any simplified technical law or minimum requirements in place in your countries for selling do-it-yourself personal protective equipment, PPE, such as face masks or face shields, etc.? Any comments?
So Zhang, in the US, the CDC has put out recommendations as to minimum requirements. They have been flexible about using N95s, N100s, N101s, which exceed N95 standards from other industries, to utilize those as PPE within the hospital. We've also leveraged our partners in the state that are manufacturing partners to start manufacturing other types of PPE, such as disposable gowns and face shields. Those minimum requirements are available, and manufacturers have been starting to spin up in our state alternative supply chains to go ahead and drive some more PPE into the flow.
Yeah. Okay. And here is a new question popped on from the online. The question says, hello, any specific instructions possibly based on international guidelines on cleaning and disinfecting medical equipment specific for COVID-19? Are there any specific disinfecting guidelines or procedures for medical equipment for the COVID-19?
So Zhang, in our organization, in our state, most of the manufacturers have provided us updated guidelines for cleaning and what quaternary type of cleaning supplies you can use that will kill the COVID-19 vaccine or virus. I will tell you, it's been a challenge as we have so many different manufacturers that we work with to gather all of that information. There is no central database to tell you how to clean every piece of equipment. You have to go to every manufacturer specifically and ask about that piece of equipment.
Mm-hmm. Okay, here comes a rather simple question. Maybe it's not as simple as it appears. What kind of equipment you witnessed during fighting this COVID-19 broken most easily, have the highest troubleshooting rate? Ventilators, infusion pumps, or the DR or CT, or monitors? Which one?
So I'll tell you, our experience has actually been that repair volumes have dropped dramatically. Nursing staff is taking good care of their equipment and they are using them in a way that doesn't make them fail at this point. So we're not seeing a lot of repairs, especially during peak times, because that equipment continues to be used. I will tell you, we've had a few extra CT and X-ray calls because they want to utilize that equipment for imaging. But the ventilators and the pumps, we've done a lot of preventative maintenance ahead of time. And so we're not seeing a large repair volume in either one of those categories.
Okay.
And I would echo that. And I think a lot of that has to do with the fact that we have discontinued all elective surgeries within all of our facilities. So actually, when we first started out, our census within our acute care facilities dropped drastically because we weren't doing elective surgeries anymore, which means that a lot of that equipment was not in use at the time. But so as our census begins to ramp up, then the equipment is utilized a little more, and we might see some things like that. But we're the same. We don't have anything that's specifically that we're seeing a high rate of failure.
Okay, thank you. We got many questions from our audience, and here are two for our Chinese speakers. Question for Dr. Zhang Qiang. The question is, adopting information technology solution to correct patient medical equipment data and monitor them outside the patient rooms can reduce frequencies of doctors and nurses entering the rooms. Are there such examples in your facilities in Wuhan to share with us? 张院有个问题问你，就是一个应用 IT 来隔离医疗设备跟病人的一个连接。那么这样的话，医护人员可以少进去那个负压病房或者隔离病房或者是 ICU， 来减少感染以及节省 PPE 的这种东西。
对，我们这个一方面我们在移动推车上安装了这个视频监控设备啊，可以推到 ICU 病房的这个患者床前啊，观测病人的实时状况，然后再通过无线网络传输到接近区的医生工作站。另一方面呢，我们将隔离病房和 ICU 的这个中央监护站通过临时的光纤啊并接到接近区，可以使得医务人员监测患者的生理参数，这样可以减少医务人员进入污染区的次数。谢谢。
Okay, thank you very much. So Dr. Zhang is make 2 points basically. One is using a mobile cart, move around is a more general word, like for the moderate patients, or using the mobile cart and collect the data and transfer either through the Wi-Fi and can monitor outside the room. And for those negative pressure rooms or the critical patients rooms, they install the central monitoring system, so can also separate equipment data monitoring with the patients. That means you don't have to get the data from the bedside. You can get the data outside the rooms. Okay, thank you. Another question is for Director Chen. Let me check. Do you have any practical and acceptable means to disinfect and steril relevant equipment, such as ventilators and monitors, and enhance their turnaround rate? 一个陈主任有这么一个问题问你，你回答一下看。
好的， 我是觉得其实呼吸机监护仪啊，它作为这个急救生命支持类设备，在这次疫情的救治中起着举足轻重的这样的一个作用。那对于这一类的跟高传染性疾病患者密切联系的这样的一个设备呢，其实我觉得消毒的原则应该是一人一用一消毒。那么我们如何去快速的去做到这样的一个消毒？那么快速并不是说以降低我们的这个设备的质量，来去达到快速，那是有一定的方法的。我想了一下呢，可能有以下这几个方法吧。第一个呢，就是我们的临床工程师呢，他必须要熟练的掌握我们消毒灭菌的这样的方法，制定一个标准的 SOP 这样操作流程，然后才能够做到快速。再一个呢，就是要通过我们的各种途径，譬如我们几级购置啊，譬如我们全院统一调拨呀，比如精神监证啊，比如工程师发挥自己的能动性去制作呀等等这样的方法来增加消毒类的设备。再一个呢，就是要这个我们增加我们的人员，实行这个譬如7×24小时这样的一个轮班制，然后用更多的人员去保证我们这个一线的设备的来这个快速的消毒。谢谢陈主任。
Okay, and thank you very much. So, disinfection, the relevant equipment during the epidemic is very important. And without sacrificing the disinfection or sterilization quality, we managed to use basically 3 means to enhance the turnaround. The first one is training, and training the people so they can strictly master how to disinfect and sterilize the relevant equipment. The second way is we try as possible to increase the volume of the relevant equipment, such as we purchase or we get more infusion pumps, or we also can increase the disinfection or sterilization machines. The second way is we arrange appropriate shifting. So we may arrange more people and around the clock, whenever there is a need, some of the important equipment needed to disinfection, and we just do it. Okay, thank you. So because of limited time, today's webinar is approaching to its conclusion. At last, I'd like to invite every one of you, the panelists, to sum up your COVID-19 fighting experience with one sentence, or express your best wishes to people around the world. Let's begin with the 2 Chinese experts, Dr. Zhang from Wuhan and Ms. Chen from Guangzhou. 张院，你要么总结一下，用一句话来总结一下，然后讲完了以后呢，再是陈主任讲一下。
OK， 这个武汉的疫情能够得以控制，我想我们医工人的努力功不可没。那么在此呢，我也祝愿全球所有的医工同仁们保重身体，为这次全球抗疫保卫战贡献力量。
好，说得非常好 ，Thank you. So Dr. Zhang just said the epidemic in Wuhan has been contained pretty well, and partly owing to our clinical engineering's contribution. And here, he wished all the clinical engineering professionals around the world stay safe and make more contributions fighting this pandemic. 陈主任。
好，我想说的是，无论遇到多大的困难，共担风雨，我们在一起。
Okay, thank you. So Director Chen just said, no matter how big the challenge is, by working together, we can and we will get through it. Okay, thank you. So, Mr. Mike Busdicker, would you please to sum up with one sentence?
It's difficult to do with one sentence, but
You can use two sentences. Okay, sure. No problem.
I very much appreciate all of the experts that are on the panel sharing data and information. And I think that that's the only way that we're going to get through this pandemic is by sharing data and sharing information and working together across the borders, across the lines, across the countries, and working as one. And I'm very excited about that. What this is, not excited about the pandemic or anything, but how it's generated the collaboration and working together as an industry in clinical engineering to fight this pandemic. And you're right, we'll stay together, we'll stay strong, and we will get through it.
Thank you. Sam?
Yes, I agree with all my other panelists. I think this pandemic has provided an opportunity for us as HTM and clinical engineer to collaborate in a way that we haven't in the past. And so I look forward to future collaboration. And please, use each other, use us as your panelists to help you through this difficult time. So everybody stay safe and be well.
Thank you. Professor Iadanza?
Yes, thank you. Well, as we started saying in China 2015 with the first clinical engineering and healthcare technology management conference, we said together we can make it better. And I think it's correct. Nobody of us, I hope, has been feeling alone in these terrible days because of the possibility to share knowledge, to share information, but also, friendship, and also knowing that you can jump on some giant's shoulders. So I think in this very difficult time, we are also proving how our profession has been growing through the last years. And that's to close with a good note.
Great. So it seems working together and we can make it better is a key sentence. Well, we believe your sharing and wishes will spread all over the world via our live streaming. Let's try efforts with fellow nations to help each other and overcome whatever difficulties that lie ahead. I wish the pandemic of the COVID-19 will be curbed as soon as possible. We will see the sunshine after the rain, and it's 10:40 minutes time, Beijing time, on the night of April 10. At last, I want to thank all the guest speakers very much. Thank you for your contribution. And I also want to thank the organizer, our host, and all the online audience. Stay with us. That's all for today's live streaming. Take care, stay safe, and see you. Goodbye. Bye-bye.
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 Bye.